Hi everyone, and welcome to the Quality Network for Prison Mental Health Services webinar. We're hosting this webinar with fantastic collaboration from the RCGP Secure Environment, SMMGP, and my name is Kate Townsend and I'm the Programme Manager for the Quality Network. So today's webinar is on the topic of the new technology platform Visionable. So this is a newly developed system which will enable remote consultations for clinicians working in prisons. NHS England Health and Justice has invested in a 2-year pilot of telemedicine across the entire secure estate in response to the COVID-19 pandemic. Although we are seeing community services starting to return to normality, the reality is that sadly this is not the case for the prison environments where patients remain in their cells for extended periods of time. So the aim of the webinar is to learn more about Visionable and explain the national rollout programme and the implications this has for clinicians working in the secure estate. So you'll have the opportunity to ask questions to the people who've designed the platform, and we'll also have insights from clinicians, both the novice and the experienced, to help cover how this will work in reality. So we really want this webinar to help clinicians, so primary care, mental health care and substance misuse, to understand the benefits of the remote consultations and the Visionable software that's being rolled out across the prisons. So we want this to be a very practical and informative webinar on how to use it, why we should use it, and the possibilities to enhance patient care and experience. So firstly, just to introduce today's speakers, we've got Chantal Edge, who's a Specialty Registrar in Public Health, an IHR Clinical Doctorate Research Fellow, who's leading on the telemedicine rollout programme. So we've got Lee Henderson, who's from Visionable, who's a Technical Manager responsible for NHS England and HMPPS Visionable services. So he'll be able to answer any technical questions. We've got Caroline Watson, who's playing the role of the novice clinician. She's the lead GP at HMP Bedford and RCGP Clinical Champion for Healthcare in Secure Environments. And finally, we've also got Ian Brew, who's the National Deputy Medical Director for Care UK's Health and Justice team. So Ian has special interest in telemedicine applications and will be inputting as our experienced clinician. So just to quickly mention some practical things before we begin, the webinar will be recorded and we'll be making it available after today for anyone who couldn't catch it live. So we encourage people and everyone to ask questions throughout. There's a Q&A function at the top right hand side of your screen. So some questions might be able to be answered by text, but if not, we've saved a good 15 to 20 minutes at the end to go through any questions with today's speakers. So without further ado, I will pass on to Chantal.
Hi, thank you for the introduction, Kate. So as Kate said, my name is Chantal Edge. I'm a public health registrar and I was out of my training for the last 2 years doing a PhD on prison telemedicine based in Surrey, and it was terribly difficult before the pandemic to get telemedicine or video consultations running, but we had a sort of silver lining in the light of the pandemic where telemedicine became a priority for everyone, and at that point I moved to work with NHS England Health and Justice to lead on the rollout of telemedicine across the secure estate as part of pandemic response. So just to start with this slide before it sort of stops any questions in its tracks, a lot of people say, well, yes, everyone's using telemedicine, everyone's doing video consultations now, so why the big deal about talking about what we have to do in prisons and other secure settings? And the issue is very much that we can't just adopt any technology that we would like to use. Because we are in HMPPS's buildings and under their domain, we have to abide by their rules around digital technology, which means that the HMPPS central digital teams have to approve any digital technology that's going to be used in prisons, even if it's for healthcare services. It's a myth, unfortunately, that local governors can make approval for telemedicine or for any type of digital technology unless it has, without it having already received national approval. So a lot of people think that governors can make a decision and agree to deploy something in their prisons, but when it comes to digital technology, they aren't the final word. They can say they won't approve something that has been approved centrally, but they cannot approve something that has not already received central digital approval. So just a bit of a timeline to the pandemic rollout over the last few months. Obviously in January we had our first confirmed cases of COVID in England, and in February and March community services rushed to move to online delivery of healthcare through video consultations as part of pandemic response. And it was around the end of March that I started working with NHS England Health and Justice and very closely with the HMPPS central digital teams to assure a model for telemedicine consultations in the prison system. So we reached agreement on software and hardware that we could use quite early on in the process. So as I said on the last slide, anything that's going to be used in prisons has to be approved centrally by the national digital teams. And at the point of the pandemic, there are only 2 software options that were approved for use for patient video consultations in prisons. And these were Visionable and Involve. Both of these providers put in business cases to NHS England, and Visionable, as you've guessed, was successful. And Lee is here to talk about Visionable after I've talked through the rollout programme. So we agreed that Visionable will be the software that was used for video consultations in prisons. And then we also had some discussions around hardware. So HMPPS were very happy for us to use webcams on PCs for delivery of telemedicine calls, so PCs in healthcare. But they also gave us rather groundbreaking approval to design very secure 4G enabled tablets for undertaking telemedicine calls and accessing System 1 medical notes in the prison. We've been working over the last few months to try and design, procure and roll out both these hardware and software technologies. So the tablets should be coming very, very soon. There will be 1 per site, and they've been hard to build because you can't just take a tablet and add software to it for HMPPS. You have to take things off. You have to make them as secure as they would like them. So we've had to have a bespoke tablet model designed that will allow us to use the Visionable software and access System 1 on it. And that comes with a lot of issues in itself. We've had to work out how to use smart card logins, how to access the health and social care network over 4G connections so that people can log in. So it's been a lot of work, but the tablets are nearly configured and ready to roll out. And the Visionable licenses have been rolling out over the last month or so to those who have been allocated one by their heads of healthcare. So if you have received an invitation to sign up to a Visionable license, if you check with your heads of healthcare, it's very likely you were nominated. We'd be really pleased if you would sign up to activate your license. So to recap on what everyone's going to be receiving in England, so every English prison, immigration removal centre and children and young persons secure estate establishment will receive some Visionable software licenses, not one for every single staff member, but a handful ranging from sort of around 12 to 25, depending on the size of the establishment. One of the NHS England funded 4G tablets, which will be enabled for Visionable telemedicine calls and access to System 1. Webcams for PC-based telemedicine. And just to note that, as Kate said, this has all been funded for a 2-year pilot, so from June 2020 to June 2022. And all this equipment has been funded centrally by the NHS England Health and Justice team for the duration of this pilot. So just to touch on a few rules around video consultations, and these are HMPPS rules we have to abide by when we're using them. So first of all, as I've said several times previous, they have to be undertaken using approved software. You can't use MS Teams, you can't use Zoom, and we can't even use Attend Anywhere. It just doesn't have the digital audit trail, which I'm going to touch on in a minute. So you can use Visionable and you can use Involve, and anything else constitutes a security breach. Clinical consultations must be confidential, they mustn't be recorded. And every patient must have a chaperone throughout the duration of their internet consultation. They're not allowed to be left with the internet unsupervised. So the chaperone should ideally be a member of the prison healthcare team, and that prison healthcare team member will log into Visionable on behalf of the patient with them, but they'll log in on behalf of the patient using their own individual Visionable account. And this individual account is really important because it allows HMPPS to track back to the individual if there's any misappropriation of the system in the future. In terms of uses of video consultations, Caroline and Ian are going to talk much more about this, but I just wanted to touch on an analogy I've used quite a few times before, which is when an organisation rolls out MS Teams, it doesn't tell its staff what they have to use MS Teams for. It doesn't say you've got to use it for this type of meeting, but not this one. And the same applies to Visionable. We've had a lot of clinicians saying, you know, what do you want us to use it for? Are you going to tell us what to use it for? And the answer is no. That is up to you for what you feel is clinically appropriate. But we would like people to think widely and think about how they could use it, not just only to deliver services in pandemic context, but also if they can make services more efficient or access services that are traditionally hard to reach in the prison environment. So some examples here that have been put forward, and some people are looking at pilots already. So primary care services, mental health, we've had interest in dentistry services for remote triage, sexual health, we're in discussion with several SARCs about sexual assault counselling, substance misuse and contact with substance misuse teams in the community through the gate, assessments under the Mental Health Act, and of course secondary care appointments, which is what a lot of people think of when they think of prison telemedicine. So how is the system set up that we can make calls? When I first started doing this a couple of years ago in Surrey, one of the rules HMPPS set at the time was that prisons were not allowed to make outgoing calls. They thought this restricted it, made it much less likely a breach would ever take place. But they have since realised that that severely restricts the use of the system, and in light of the pandemic they changed this rule so that prisons can indeed make outgoing calls as well as receiving them. And there are two ways we can make calls. So we can either make calls where both ends of the call have their own Visionable license, so the clinician in the prison or the chaperone in the prison and the clinician external to the prison, or we are now as well, which is new for the pandemic, allowed to make what I call one-way calls. So one member of the call party, so the party within the secure setting, has their own named Visionable license, and the remote clinician just clicks on a URL and joins a link to a meeting that they were invited to, even though they don't have their own Visionable license outside of the prison. So this means it opens up the ability for people in prison to make calls from both the telemedicine tablets and the PCs, for instance, to other secure settings, be that another prison, be that an IRC, to pool resources between those settings. Do note that if you are calling another secure setting, obviously both ends of the call need to have their own identifiable Visionable license. You could make a call from the prison to a remote clinician who may be shielding or isolating or just working at a hub service in the community. You could call a hospital, and you could call a psychiatrist at a secure hospital. So there's many ways you can just configure the calls to access different healthcare professionals. Coming back to the audit criteria, which I've touched on a few times, HMPPS, as I've said before, are very concerned that misappropriation could occur with the system. And the reason Visionable meets the criteria for their secure audit of these systems is that, one, it can be locked down, so you can't dial anyone unauthorized on the system, and two, it has a really strong digital audit trail. In their opinion, written audits and log audits are not acceptable. They want a digital audit that can be pulled essentially at a push of a button. And HMPPS could ask to audit usernames, so who has Visionable licenses on the server, who they've called, how many calls they've made, how long those calls were, who they dialed, who they invited to meeting, and who the approved contacts are added to the telemedicine system. Just to note on that front that when sending meeting invitations to people who don't have Visionable licenses, you'll automatically be able to send those invitations to people with NHS email addresses. And for those without NHS email addresses, you'll have to have the email added by an administrator to the system. And this is all to assure accountability and misappropriation are auditable from the HMPPS perspective. So I'm sure Lee's going to talk about this a bit more, but just to confirm, I have been told that joining a meeting as a guest is a very simple process. So you just need to work with the healthcare team in the prison to set a time and date for the video appointment, provide an email address, preferably, like I said, an NHS email address, just because it will be very simple, automatically permitted by the system. Receive your meeting URL and click on it in the day to join the meeting. I would note that if you're going to forward the invitation to someone else, because you can't join on the day, you do need to let the healthcare team know. Forwarding the meeting link without warning will count as a security breach, because obviously in principle you could be forwarding it to anyone. So that needs to be reported before you send it onwards. And just the very last point for me, there is a national evaluation being designed for the telemedicine rollout. We're trying to embed data collection in System 1 as much as possible, so it's not too onerous for teams to collect data. We'll be focusing on three main parameters, which is access, quality and cost. So under access, we'll be looking at whether telemedicine improves referral to treatment times, numbers of appointments, DNAs, cancellations. In quality, we'll be looking around prescribing indicators, whether clinicians found it acceptable for their clinical use, and also around patient satisfaction through questionnaires and interviews. And finally, as well, costs. And everyone automatically presumes it will be cost saving because we'll reduce escorts going out to hospitals or other services. But actually, you do have to factor in the fact that there will be a chaperone with that individual in the prison who would have been doing something else if that patient had gone out. So the cost needs to be looked at as well. We do have a future NHS collaboration platform. The link is here. If you opt to join up, we just ask for an invitation and we will permit you entry. It hosts all our SOPs, all the current guidance, all the communications documents that have gone out, links to new webinars coming up, etc. So it's for all secure settings for RCs, children's and adult prisons. And my emails are at the bottom, and I'm always very happy to take any inquiries as well as questions today. Thank you.
Thank you, Chantal. Lee, I'm going to send you live if you wouldn't mind just sharing your presentation.
Right, do you have my presentation?
Yeah, you're just going live now. There you go.
All right, well, good evening, ladies and gentlemen. Thank you, Chantal. I think you've covered most of the bits and pieces. Anyway, I shall just speak about, Visionable in NHSE and HMPPS. We'll get to the next slide, that would be good. Okay, I'm going to run through just a brief introduction to Visionable, the use of Visionable in HMPPS, a little bit of how actual Visionable is set up and you're going to use it, the ins and outs of a successful meeting. These are quite key, and they actually, if you get them right at the outset, it means that everything works quite sweetly. We'll also cover a little bit of future training where you can go and have a look if you've forgotten how to do various bits and pieces. And then what I'll do at the end is I'll do a very brief demonstration running from my laptop out to an email, and I'll show you that on the screen as well. So, introduction to Visionable. Visionable has been around for 25 odd years in different guises, in SAWS and then IACOM, initially set up to monitor oil rigs via satellite, which is running over high latency, low bandwidth systems, obviously, because bandwidth via satellite is hugely expensive. So that's exactly what it was designed to do. It's been running for the last 12 years at Imperial, which is a group of hospitals in Northwest London. About 12 years ago, they set up the Northwest London Cancer Network, which looked after 10 hospitals, 16 multidisciplinary team rooms. And they're sharing, as you can see on this side, things like CT scans, microscope images. And this is just a very brief screenshot, but you can see there's an MDT in process. High definition images that you can zoom in on. And the ability to link multiple parties. It's not like Teams as we're in now, where you're all sort of squashed into one window. This you can share across and you can spread across different screens. So if you imagine these screens here, the two 85-inch screens in a room, you can maximize the CT scan to one of those 85-inch screens, and you can really zoom in and get the detail. So this is primarily what it's been used for, but now it's expanding out. We carry the Surrey and Sussex Cancer Alliance. We're up in West Suffolk. Southern Health, Torquay and Torbay, and we're spreading up through the Midlands, and it's becoming lots of different applications as well. Things like smart ambulance, the ability to bring video conferencing into the back of an ambulance on a paramedic's wearable device on their shoulder to get immediate clinical expertise via an earpiece, so the clinical clinicians can see exactly what's going on. If you look at this, where we are in hospitals, what we're trying to do is effectively link at every part of the hospital together, so that you've got various. I mean, here you've got the ambulance part, you've got translators in the different office. So obviously, if you're talking to different people, translating languages, you've got patients, you've got outpatients, you've got patients actually in wards, and so on. So there's many different applications that we're putting together. This is just a short list of where we're currently working across these hospitals and these STPs. It's expanding very quickly, especially after the COVID pandemic. And I think in February and March, April, we set up some 2,500 clinicians who would normally attend things like MDTs. They wanted to start attending from home, and this is again sharing things like radiology images and so on. The here, Visionable in HMPPS. This is how all of our systems are set up. We run everything in Amazon, in a virtual private cloud in Amazon. Now, everything is totally locked down there, and we can make it so because the firewall surrounding the virtual private cloud only allows us in initially just to create the firewall. So then at that point, we can say, okay, this specific IP address can talk to this specific IP address on these particular ports. So we know that no one else can come on board and no one else can go into that system. Also, everything is encrypted AES 256. That's data in transit and data at rest. When we say data at rest, the only data we store actually in the database within Amazon is the IDs, and as Chantal said, it's the IDs, the time when the meeting actually started, the IP addresses of the parties, the time the meeting started, the duration of the meeting, and the number of parties. That's the only data we store, so there's no identifiable data. Now, this is why when we were going out through the various trusts across the NHS, obviously we were very keen to have the Call to Guardians sign off a particular document called an SRO, which I can send to you if you'd like to see it. It details everything in terms of information governance, GDPR, everything in terms of IT security. And as it says there, we basically, we use the highest level of security that AWS can offer. In this quick sort of diagram, you can see here, everything's broken down into communities. So effectively, the green community there would be everybody who's in prison C would be able to see everybody in hospital B. And ideally, that's how it was going to be set. And then with some certain sort of anomalies where someone from prison C could see someone from hospital A or speak to someone from hospital A in a completely different community. We've opened the doors now, as Chantal said, by allowing people to invite people via email and secure email. So that now means that if you've got an NHS email address, or again, as Chantal says, one that's actually been specified that you can receive an email invite, now it can actually be spread out and go out to various other people. Using Visionable in HMPPS, the idea is to reduce the number of visits and associated costs to related hospitals, decrease the delay in diagnosis. I mean, instead of waiting a day or so, a patient could actually be seen very much quicker. If there is sort of a clinic on that particular day, you go up to the health part of the prison and you can possibly see a GP or clinician straight away. If there's something that becomes a little bit more requires a little bit more diagnosis, you can pull in a third party or a number of third parties into that meeting to talk to and discuss various images. As you can see here, this is actually an ultrasound scan of a carotid artery, and that's again in high definition. Effectively, you can share images like this, the X-ray, CT scans, and everything for discussion. Sharing high definition images. As you can see, if you can zoom in on a particular break in a hand, you can see, you can look at the detail there, and it enables you to make a much better diagnosis, and it's also describe any problems that are coming up. But that said, it's not just X-rays. You can share anything, Excel spreadsheets, Word documents. You can do moving CT scans. As you're scanning up and down the body, you can see their various slides. And yeah, it says you're only limited by a screen size, so you can actually share quite a few images if required. So, Visionable in action. When you get a login, this is if you have a login, as Chantal mentioned, you have a login, you'll be given an email, you have your email address, you'll be given a password, you're given a specific server, and in this case, it's nhsehj.visionable.com. That, again, as I mentioned, is the specific virtual private cloud server allocated to NHSE Health and Justice. Okay, so again, no one else can actually get into that. And to get it to here, from this point, you actually need a username, a password, and you need to connect to that server. First time going in, it'll ask you just to set up your audio devices and your camera. So that's just a one-off. Once you've done it once, it will use the same system every time. So once you're actually in, if you have a license and you're logged in, you can navigate to the people list. In this particular one, I've got a fictitious prison called HMP Greenwood. There you can see Dr. Simon Peterson, who is online because he's green, and Mr. Barry Cordley, who's offline because he's grey. If they were blue, they would actually be in a meeting. So literally all you do is you highlight the person you want to talk to and you click invite in the bottom right hand corner. That will then send a link or send a request to Dr. Simon Peterson to say, do you want to join this meeting? It's assumed you probably had a conversation with Dr. Simon Peterson prior to that, and he knows and will be expecting you, and we'll just click accept and join a meeting. Another way of doing it is each of the communities has its own assigned virtual room. Now, because I'm a member of both HMP Greenwood and also in this case I'm a member of the HMP Lewis prison, I can see both of the rooms that are available. And I can join those rooms at any time. So again, if I decided to meet a particular doctor in that room, I can say I'll meet you in HMP Greenwood at 2:30. And literally all you do is you sign in, go to meetings and you click the room and join it, and you're linked in there. The beauty of this is the HMP Greenwood is only visible to those people in the HMP Greenwood community. Another way of doing it is creating a scheduled meeting. So here you click on the meetings tab and you click on the scheduler, or you click on add. That will then take you to this page. At this page, you will be able to type in all the invitees. You'll select the subject name, the date and time, and you schedule and send the invite. What will happen is the email addresses at the bottom will receive a link, much like the one at the bottom there, which says attend online HTTPS. It's given the Visionable detail. That's a specific unique code for that particular meeting. That will change. It will never be the same again. Once it's used, it's used. So you can join it once the meeting is finished and finalised. Behind the scenes, what will happen here is when you hit schedule and send invites, we are hoping to send this out through an NHS mail service. It can be done via us, but we're hoping to do it through the NHS mail service purely for an audit trail. So that will give the people the ability to literally look and see exactly which emails were sent out and at what time they were sent out. Again, if I'm the actual creator of the meeting, I can go back and edit or delete it if I decide I don't want to do it anymore, and I can add various other people to it and further invitees if I need to. A quick tour of the ins and outs of a successful meeting. What you sometimes have is if there's a lot of noise, joining those rooms, you will automatically be muted. You can see here the way you mute yourself is that you're clicking on the green microphone. Likewise, you can mute your own speaker and you can mute your camera, so you can hide your camera effectively. Clicking on the microphone, literally just mute yourself, and if there's obviously too much noise coming from the other end, or you've joined a meeting 5 minutes early and you don't want to hear what's going on at the other end, you just click the speaker and you turn it off. So you can happily continue on with that. Going into screen images that are sent over, then it's much like a normal Windows image. You can just literally grab any corner and drag it to make it bigger. Similarly, you can right click on your screen and you can actually select a different window size. Coming into sharing any data, any images that you want to share. Here we have, I've got the hand X-ray on the right hand side, so that's the X-ray that I want to share. I click on the sharing tab, I click on the sharing window, little icon to the right of hand X-ray JPEG, and that then gets sent to every party in this particular meeting, so everybody will see it. What they do with it is totally up to them. If they decide they don't want to see it, they can just click X in the top right hand corner if it's a Windows box, and that window will just disappear. Or they can maximize it and zoom in and have a look at the detail, all at the same time whilst having conversations with the people actually in the meeting. What we're also going to do behind the scenes is we've got on our website thevisionable.com video tutorials HMPPS. As you can see, the password there is capital HMPPS 2020. We're going to be putting a number of videos in there, just short 30-second videos to say how things work, how quickly it can be done and so on, and just if you forget, you can just jump on there and have a very quick look. Right, that's that for that bit. Okay, if I can have a couple of seconds, I'm just going to set up a link where I will actually send myself. So what I'm doing is I'm creating a meeting on my laptop here, and I'm then going to invite myself to that meeting, and you'll be able to see how this would come through. So in true Blue Peter fashion. Right, so that's how the meeting will arrive, okay? And at that point, literally, all I have to do, if it's a scheduled meeting, obviously I won't be able to join the meeting till the 5 minutes before the scheduled time, but here I can just click on that link. That link will put up this window, and I just join the meeting using a web browser. Very simple. I just do Lee guest and click OK. And then what you'll see is the device downloading. It's asking me to use the microphone. I'm happy with that. And it's asking me to use the camera. So it'll use the camera directly in front of me. And what you should see in the window next to me here is what you're seeing on the laptop. There we go, and I've just muted that so I don't get a lot of feedback. That's literally it. So now I can move these guys around, and I can have a chat with the parties in there if I need to. That's it. So that's from my laptop there. Make sure you can hold it here and you can see it. That's from my laptop. That's exactly how that's going to work when we're actually within the prisons. Okay, you can see the attendees here, so the attendees will be listed down here. And at this point, I don't know if the sharing is working on this particular system. This is not the HMPP system. That's currently in the sort of a rebuild state. This is just internal use only, so it's different demonstrations. So that's basically how it's set. Here I can mute the microphone, mute the camera, and mute my speaker. There we go. This is literally as simple as that, and if anybody else joined, they would just appear in another window, and you've got the usual bits and pieces, as I mentioned, about being able to make things larger or smaller right the way through. And then to exit a meeting, literally just click the red button and away you go. Okay, that's it from me.
Thank you. I'm just sharing my content now. Okay, so to you, Caroline.
Thank you, and thank you very much for all that expertise, Chantal and Lee. What I wanted to do was really to try and join up a few dots as to how I had it in my mind. Why were we doing this? What's the purpose? What's the benefits? Are there any drawbacks? And also to try and turn something that was an email and an inbox that might have arrived from Lee into something you thought, right, yes, this is what I really want to move forward with. We can achieve safe, effective care for our patient group here in the prisons. So this table here is taken from the latest Royal College of GPs COVID guidance for clinicians. That's the August edition. So if you haven't looked since April, this was a brand new August edition. and this is the part on remote consultations. So you'll see here that I've just got some T's and V's, the T's being telephone and V's being video call or video consultation. So really taking a step back from the Visionable and the video consultation and just saying, okay, what are we doing? We're trying to, the what we're achieving is trying to achieve safe access for our patients. And we're just having a look at the how, the changing the how from face-to-face, where COVID has made it difficult, where perhaps, as Chantal said, you may have a clinician who is isolating. We've had over the few months people shielding, you've had, and that may happen again, we don't know yet. And it also opportunities to move forward with how we can deliver healthcare. Now, clearly, digital and remote consultations aren't the answer for everything, and there definitely will be consultations that need to be face-to-face. But here I've just suggested, obviously for primary care triage, it very much depends whether you've got telephones in cells, make it an awful lot easier. Those are being rolled out. I believe it's 55 prisons. There have been more rolled out since that's being rolled out and sort of expedited, I understand, throughout COVID. So that will just enable a better use of face-to-face consultations if that is achieved, the triage side. Now, again, secondary triage, you can maybe avoid escorts to A&E and reduced referrals through a telephone consultation, a triage consultation with a hospital consultant. That's up and running with some trusts. But to actually look beyond this to the use of Visionable and the video calls, looking at the primary care consultations, it can, if you're short of staff, whether you have those who are on leave, you've got those who are having to work from home, you can have provide cross-site cover, and so that will allow patients to have access to clinicians where the number of on-site staff are limited. Prison to the community, so your remote staff would be those staff who are off-site. So you've got patient access to either a non-medical prescriber, advanced nurse practitioner, or a GP off-site. And then, as Chantal said, that what we understand more frequently is the prison to the hospital, and also prison to perhaps part of the community team, the visiting psychiatrist who isn't able to be on site for you. So those are possibilities that I have been really getting excited about. Clearly, with the lockdown and with the first wave, there was a concern that it would be difficult to get transfers to mental health secure units, secure hospitals. I think that things have worked smoothly, but there is the possibility for having your secure hospital psychiatrist able to do an assessment direct to the prison through the video consultation. And then just lastly, again, Chantal alluded to, we are looking, aren't we, at a very high risk population, people, particularly those revolving door patients, perhaps those with substance misuse problems who need to link in, whether that's primary care services, substance misuse or mental health services. If we can enable them to have a conversation or a consultation with somebody before they're released, and particularly if that could be a video consultation, so they can see face-to-face somebody from the team they may engage with, I think there is a likelihood of an increased engagement and a reduced risk of dropout from care and that revolving door scenario happening. So those are my novice ideas for what could be useful uses of both telephone and video consultations. And then I think what would be really helpful for me, and I hope others, will be to hear from Ian, who has been using telemedicine, and will be able to say actually what on the ground the barriers have been to either implementing or perhaps trying to overcome the reluctant implementers' concerns, and then also those things that perhaps don't work so well. So I would find that very helpful, and I hope that might be the case for other people here.
Yeah, thanks, Caroline. That's a really good overview of some of the potential of video. And you're right, several providers have been using telemedicine for hospital-based consultation for some years. Indeed, we've been working with a trust in Yorkshire based at Airedale, as have other providers, getting a number of specialties to look at patients and carry out consultations. And we would average about 100 referrals a month to this our 46 sites. So it's a remarkably useful resource. And I think we've touched on cost and cost savings, but I think it's really important also to remember the decency agenda for patients, because going out to hospital in handcuffs with 2 officers with you, bang goes your confidentiality, and you're likely to be attracting a load of unwanted hospital waiting room as well. So there's a number of other benefits to doing things privately with the patient based in the prison. But you are right, there's a number of challenges and obstacles that get in the way. And one of these is around getting the patient in front of the technology at the same time as the clinician is on the other end of it. And what we've seen through enablement challenges, we know that availability has been a bit of a problem at some sites during the COVID situation, and physically getting the patient in front of the screen at the time that the consultant has pre-arranged can be challenging, and that does lead to cancellations. So here, the mobile tablets and the webcam solutions make things much more straightforward to get the patient at the prison end with a chaperone, a healthcare chaperone, navigate the System 1 record if some information is required, and that should reduce some of the cancellations due to enablement issues. But obviously, we do need to have the consultant or the clinician at the other end, whether that's in hospital or, as one of the delegates has suggested, potentially sitting at home. So we need there's logistics to get right here. You're also right that some specialties are more prone to the use of telemedicine than others. So psychiatry, very little hands-on assessment sometimes. Talking is going to be the mainstay, with watching for non-verbal communications. So mental health assessments, it seems to me, could quite easily be done. Other specialties are less useful. One that we've found is ear, nose and throat surgery. And the reason for that is that it's highly likely that the patient will have a nasoendoscopy done in the clinic at their first appointment, and that's clearly something that we're not yet able to do by video consultation. Having said that, of course, technology continues to develop, and there are USB stethoscopes, so it would be quite possible to plug in a stethoscope at the prison end and allow the clinician to place that for remote working consultant to make assessment of heart sounds, breath sounds and so on. So there is technology out there that's making the non-face-to-face experience much more like a clinical assessment. So in fact, the only thing you can't do is lay a hand on to assess a lump or a bump or an acute abdomen. So huge potential here, and I think you're right to identify all these potential streams. I'm certainly planning to cover reception, remotely from home so that I can see patients and prescribe for them, and then cover absences at prisons quite distant from me. One question that came in is it possible to prescribe? So if the patient is at a prison where you have System 1 access already, yes, you can absolutely prescribe. It should, if your network allows it, to print off the script at the prison itself and get it signed later or the next time you're in. The exception there being controlled drugs, which need a wet signature on site, and they will continue to need that until we get the electronic prescribing system fully embedded. So lots of opportunity here, and we've certainly got good experiences, and we're looking forward to Visionable becoming embedded so that we can take things much further as you're discussing.
Thank you, Ian. I seem to be still live, is that right? So, Ian, that's incredibly helpful. Can I just say the one thing I don't think we've covered is the fact, and I know that Lee was talking about having multiple people in a meeting. Chantal, I'm right in saying that HMPPS will only allow one-to-one consultations, is that right?
That literally changed about 2 weeks ago. I had a discussion with them, and we're not allowed more than one patient who are in different prisons. So in fact, there was another development today. We're allowed, so let me take that back to the beginning. We're allowed meetings with one patient and more than one clinician. That's fine. They've agreed that actually that's the same as if another clinician popped into a hospital room when you're out to give multidisciplinary input. So we are allowed more than one clinician in a patient appointment now. We are also allowed to have groups of patients in one prison together and speaking to a remote clinician, maybe for group work, but the clinician is outside the prison and dialing in to that group of patients. What we can't do still is we can't have lots of patients from different prisons dialing into a group chat, because that's allowing too much sort of cross-prison discussion, which HMPPS won't allow that at the moment. But no, literally in the last few weeks, they have agreed that we can open up the calls and have them at greater than one-to-one.
I think that is, I'm really excited to hear that, because for me, that's not only opens up things like pulmonary rehabilitation or perhaps cardiac rehabilitation, providing you're able to socially distance. I'm not quite sure. It may be that others can see there's not much of an advantage to that, but I can see that there's scope and there's development. If we're moving towards groups being able to meet, I can see the moving towards groups being able to perhaps meet online as well. Kate, are we going to do some questions? Are you going to field some questions?
Hi, can you hear me okay now?
Yeah.
Is that okay? Fab. Sorry about that. I've muted myself, as such a typical thing to do on these things. But yeah, thank you so much to all of our speakers today. It's been such an interesting, such an amazingly interesting webinar, and I feel like it's such a revolutionary thing to try and get all this technology into prisons in such a short space of time. All the questions, has anyone got any questions from the audience? Every one of our speakers has been so productive and efficient. They've answered most of the ones that have come through already, but I don't know whether there's any more detail that could be gone into. Sorry, my mouse is playing up.
Kate, may I ask Chantal for a little bit of further information about people consulting from home? One of the delegates has been asking if there's any guidance available for when we're dialing in and I presume that was mainly around security concerns.
Yes, I've spoken to some people about this actually before the pandemic. I had a long discussion with one of the sexual health services locally in Surrey who were looking to provide telemedicine services, and the health advisor there was talking through her plans if she was working from home location to have, as you said in your chat, Ian, no pictures in the background, you know, a reasonably sterile background. If you've got a name badge on, just first name. Nothing more identifiable than if you just presented at the prison itself. We haven't written any particular guidance for that, but I wouldn't be surprised if some exists, as from what I understand, a lot of GPs in the community have been doing consultations from home, as well as working in offices doing remote consultations. So I can definitely look and see if there's something out there, or if not, we could think about pulling something together.
Great, thank you. We've just had another question come through from Dr. David Chin, which is, what is the time frame for getting this into large areas of the UK across trusts and prisons?
So I'll pick that up again, I guess. So the Visionable licenses have started rolling out. Well, they've been rolling out for the last few months. We've actually sent 2 waves of invitations because we have found that some people haven't been told by the head of healthcare necessarily that they were nominated for a Visionable license. So when the invitation came through, they weren't sure what it was, which is exactly why we want to do webinars like this, so we can get the word out there. So those invitations have gone out. If people are expecting one and they haven't received it, let us know because we can get it resent out, but that should be available now. The tablets should be coming any day in the next couple of weeks. There's just one final issue with function keys for System 1 that they're working out, and then they're ready to dispatch. So they should be coming ASAP. The webcams have already been dispatched. They were meant to arrive at all sites by the end of today. And in terms of the hospitals, so actually 2 briefing notes have gone out nationally, one to all general acute trusts, and one today to all secure hospitals about the Visionable system, and really briefing these sets of hospitals that prisons have to do something different. They can't use Attend Anywhere, it doesn't have the audit trails and controls, and that they've got to use Visionable, but that they will be able to send invitations to those hospital staff to join without them having to get Visionable themselves, unless they want to get Visionable themselves. So we have sent out those notes. We are briefing as many people as we can, but we have said that it is really up to the local providers and the local prisons to go and have those conversations with their local hospital and say, we have this video software now, could we start working out some care pathways? And hopefully by having those direct conversations with the hospital and the prison, it builds a more sustainable relationship to keep that in place, even if video consultations drop off in the community in the future. Who knows how it will go as yet? But they are being briefed, they have been briefed nationally, it shouldn't be a complete surprise. We do have those briefing notes uploaded on our NHS Futures platform that I gave the link to in my slides. So really those conversations can start ASAP.
I wondered, just coming back in there, it's Caroline again, whether would it be useful, I don't know, Ian, your thoughts, for a clinician to because often it's the hospital who will send the invitation out, and certainly over the last few months we've been getting telephone consultation invitations, whether it would be useful to put on the bottom of a referral letter that we are able to offer video consultations and that contact. Can you see that being of any additional benefit to the commissioners approaching the hospital, the secondary care providers, Ian?
I think that's possible, Caroline. One of the difficulties that I'm finding is that an awful lot of hospital trusts aren't using Visionable. They're using the Involve platform or Attend Anywhere or the other platforms that are available. And then they're at how they are supposed to interact with us using Visionable. My ultimate aim, I suppose, is to seek to use the video consult for first appointments wherever possible, but it's going to take some legwork getting those arrangements in place with the trusts, and Chantal has very helpfully produced some slides to help us open those dialogues with colleagues. I think it's certainly something that we can look to do over time. I discovered the other day that if we have a very specialized consultant who may just do one ad hoc consultation every 6 months, maybe neuroendocrinology or something like that, that we can invite them as a one-off guest for an ad consultation without the need for a Visionable license. And Lee might be able to come in and just tell us about the quality that would be available with that sort of an ad hoc consultation. But I also discovered that hospitals are able to share licenses at the secondary care end within a department, so they don't need individual licenses as we do at the prison end. And Chantal, again, maybe you could confirm that. So yes, Caroline, there's a lot to be said for trying to develop these relationships with our secondary care colleagues.
And yeah, I can confirm that if hospitals want to have full Visionable licenses at their end, they don't have to have individual level ones. HMPPS is less concerned with them, is happy for them to share a login, so have a clinic login, as long as the hospital itself obviously can work out how to share that password securely. It's really at the prison end and the staff that are working in their establishments that they want to be able to look back to the exact individual to see if anything ever went awry.
And also, Ian, if they, within the hospital, they actually have a full license there, they have the ability to share multiple documents. From the point of being invited in as a guest, you are unable to share any documents from if you're on a web browser version. So yeah, if you wanted to share some high-level documents and that sort of thing, high definition, it'd be far better to have a license.
Thank you. Chantal, I've just seen that you've replied to the question about NHS Wales and the Welsh prison estate. So I don't know if you want to go into more detail, maybe about the Scottish and Northern Irish before we round up.
So I think Scotland for a long time have been doing something very different, and they do use Attend Anywhere up there, but they are not under the jurisdiction of HMPPS as we are. HMPPS did review Attend Anywhere. In fact, I was on a call with NHS Wales, Attend Anywhere and HMPPS Digital, and even Attend Anywhere said at the time, we can't do what you need us to do. So that's why it was so very clearly a no at the time. And Wales have been looking as to whether they could adopt Attend Anywhere because their health boards had opted for it for the hospitals. So they're going back to the drawing board, and they are very aware of what's happening in the English prisons, what's being rolled out. They are in touch with the company building the tablets, etc. So I don't know what they will adopt yet, but they may well go down the same or similar route.
Great, thank you so much. As it's sort of 28 minutes past, I think that's a good time to round up. And I just want to put a big thank you out there to all the speakers again for this really interesting and helpful webinar. And I hope everyone listening has found it helpful as well. If anyone has any questions sort of afterwards, then please do send them in either to the network, or Chantal has shared her email address on the Q&A there. And I'm sure that everyone would be happy to answer any questions. As I mentioned at the beginning of the webinar, this will be made available on the website. So please, and we'll be sending around an email to notify everyone signed up about that. And we'll also send around some feedback. So we'd be really interested to get your feedback about how you found this webinar. And just one other thing to mention is that we'll be having our annual forum coming up towards the end of the year, and we'll be sending some more information up around that. All right, thank you so much everyone for attending, and I hope you found it useful. Have a good evening.